All right, let's start. So this is the patient, Mr. Manso. You
Hi,
can
good
start.
evening. Hi,
Mm-hmm.
good evening. Am I speaking to Mr. Manso, 32 years old?
Yes, yes, I am Manso.
Hi, I'm Dr. Chiu. I'm the doctor in the clinic today.
Mm-hmm.
I'll be taking history and examining you. Is it okay for you?
Yeah, sure, sure.
Okay. I understand that you have been having this difficult swallowing. Can you tell me more?
Yeah, doctor. So I realized that actually for the past 3 months, I feel I have always have difficulty to swallow. I am not sure what's the reason, doctor.
Okay. Can I ask, did it started suddenly or gradually?
Yeah, it started gradually. Initially, I have no issue. I didn't even realize I have this problem. But suddenly, gradually, for the past 3 months, I feel like I can swallow, but somehow the food seems like stuck at the front of my chest.
All right. Is it getting worse?
Yeah, I would say getting worse. That's why I'm very concerned.
Okay. Can I ask what kind of food that usually gets stuck?
Yeah, so usually, initially was just feel like a bit those hard food is very difficult for me to swallow. And then, but now even soft food and even water, sometimes I feel is actually very difficult.
Okay, can I ask where is it the location that it gets stuck?
Yeah, like I say, I feel like somewhere near my front part of my chest, somewhere around here.
Chest there. Okay, sure. Do you have any vomiting?
No, no,
Any food that comes out after you eat, after you swallow?
no, no, no,
Okay. Do you have any uh cough or choking episode?
no.
Okay. Do you have any limb weakness associated with the swallowing problem?
Sorry, what is lameness?
Sorry, your any weakness over your hands or legs?
Oh no, no, I can still walk.
Okay. Do you have any headache?
No,
Okay. Do you have any sense of acid taste in the mouth coming out, like vomiting out from the mouth?
no, no.
Okay. Do you have any like abdominal pain, or you feel your tummy is bloated?
Tummy pain, bloating. Yes, sometimes I do feel a bit of bloating, but not really any pain.
Do you have any change in weight?
Perhaps for the past 6 months, I think I have been losing weight slowly. I used to be a bigger in my muscle bulk. Now I think I actually lost about 5 kg for the past 6 months.
Okay. How's your appetite?
My appetite hasn't been great because I can't really swallow much.
Right. Okay. Is there any fever before the onset of your difficult swallowing?
Now you talk about fever. Sometimes I do feel my body temperature is a bit on the warm side, but I never really checked my temperature before. But sometimes I do feel a bit chills, especially when I towards the end of the day, like at night before I sleep.
Do you have any sweating at night?
Yeah, yeah. Sometimes I after I slept, I have to wake up from the sleep because I need to change my shirt. It's very sweaty.
Do you have any cough for the long duration?
No, not really.
Do you have any contact with TB patient?
Sorry, what is TB?
Do you have any contact with a patient with suffer from infection which is known as tuberculosis?
No, not that I know of.
Do you have any cough with blood?
No.
Do you have any lumps and bumps?
I didn't aware about that.
Any swelling at anywhere part of the body?
No.
Okay, sure. How's your Do you have any weather preferences?
As in,
Do
cannot
you,
tolerate hot or cold? No, no.
yeah.
Has been the same.
Do you have any rash or spot or pigmentation?
No.
Okay. Okay, sir, can I ask, do you have any medical condition diagnosed in the past?
No, no, I don't have any medical problem before.
Okay, for the difficult swallowing, do you have anything that it makes it better?
I don't think so. But doctor, I do have pain when I swallow though. I think this pain is also something that quite worry for me. Only when I swallow, when the food stuck, I will feel pain.
Okay, okay. So, um, all right. So, do you have, um, are you taking any medication to relieve the pain?
I have tried with some paracetamol, but it does not really work.
All right. Beside paracetamol, are you on any regular medication?
No,
Do you have any allergy to any medication?
no,
Are you taking any traditional or medication or supplement?
no.
Have you undergone any procedure such as radiation recently?
Oh, no, 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 no. Why should I, doctor?
Okay, I just want to make sure you don't have any procedure done prior to the swallowing problem.
Okay.
Okay. All right. Can I ask any surgery done before?
No.
Okay. Any family member with a similar problem?
Not that I'm aware.
Any family history of cancer?
No.
Okay. Mr. Mansur, are you married?
No, I'm not.
Okay. So I'm going to ask some sensitive and question. I hope you don't mind. But it's important to help with my diagnosis. Can I ask? Are you in any? Do you have any partners, sexual partners?
Sexual partners, probably 1 year ago.
Do you have any unsafe intimate relationship before?
Yeah, last time I do have with my partner.
Okay. Um, so, but what about do you have any do you use any injectable drug or party drugs?
No.
Okay. Okay. Can I know what do you do for your living?
Yeah, I work as a IT serviceman.
Okay, all right. Do you have any travel history before the onset of the symptoms?
Before, as in, I used to go around the world and travel, but I think last I go was actually to America. It's about 5 years ago. But after that got COVID and then quarantine. I didn't go anywhere else.
All right, sure. Sorry, I just want to ask a few more questions regarding a few sensitive question. Do you have any tattooing or ear piercing before?
No,
Okay. Okay. So, can I ask, before I examine you, can I ask a few more questions? Do you have any blurring of your vision?
no,
Do you have any racing or pacing of your heart?
no,
Okay. Do you have any difficult breathing or
no,
chest pain?
no,
Okay. Do you have any change in your motion habit?
not that I'm aware. It has been regular.
All right. Um, okay. Okay, sure. Do you have any problem walking? Like, do you feel that you are very slow and you have any problem doing your tasks daily?
Not really. If you ask about my daily activity, I think this swallowing is really troublesome for me. I have no appetite, and then I can't eat well. I feel my whole body is weak in general. I can't really do the work that I used to do.
Okay, sure. Okay, a few more questions. So do you have any skin tightening or when you got exposed to the sun, you have the rashes on your face?
No, no,
Okay. Do you have any change in color of your fingers when exposed to the cold?
no,
Do you have dry eyes or dry mouth?
no,
Okay. So can I examine you?
Yeah, sure.
Okay. First, I want to look at general appearance. Is the patient cachectic?
Yeah, I can see the patient doesn't seems to be cachectic.
So it's not cachectic, right?
Yeah, no, just like the photo.
Okay. Okay. Was there any uh tattoo on the body?
No,
Okay. Is the patient pale?
you can see it's pink.
Okay. And is there any recent injection mark over on the hands,
You
upper
don't.
limb?
Yeah, there's no injection marks.
Okay. I would like to check the oral cavity. I want to look for any oral thrush.
Yeah, this is the photo of the tongue.
Mhm. And what about the throat?
The throat, you offer to check the throat patient. Yeah, you can see some whitish plaque over the back of the throat as well when you shine
Okay.
the torchlight.
Okay. Any oral ulcer?
No.
Okay. Okay. I would like to proceed to check the neck.
Mhm.
Is there any cervical lymph node?
As you feel the neck over the right side, you don't feel anything. But when you feel the left side, particularly at the lower part here, you feel there's about 1 cm times 1 cm lymph node at the cervical region.
Okay. And all right. Is there any rash or spots on the chest or trunk?
No.
Okay, I would like to auscultate the lungs, and I want to look for, check is there any bronchial breath sound.
Okay, the breath sound as you go from the upper zone to middle zone and lower zone, the breath sound is equal. You don't hear any bronchial breathing.
Okay. What about the axillary? Is there any lymph node over there?
When you feel for it, you don't appreciate any lymph nodes.
Okay. Is there over the arm? Is there any BCG scar?
There's no BCG scar.
Okay. And I would like to check the abdomen. I would like to feel for any hepatosplenomegaly.
So when you feel the abdomen is soft, non-tender, you can't appreciate any obvious mass. You have to do with deep palpation. Then I will minus about 30 seconds.
Okay, okay. Okay,
Okay,
I'll
so two
see.
minutes left.
Okay, I would like to check. Last is the neck. Is there any swelling, thyroid swelling?
There's no anterior neck fullness.
Okay, sure. Okay, so, can I ask, do you have any concern?
Yeah, doctor, I have a lot of concern. What am I having?
Okay, I believe that you are having a condition. Your difficult swallowing is due to some infection on causing it, and I would like to run further tests to confirm it.
Okay, do I have cancer?
At this point of time, I don't believe you have cancer, but I will make sure the investigation will exclude it.
Okay, then is this condition curable?
Yes, sorry, this condition is not. I think this condition is not curable, but it's controllable and manageable.
What, sorry, what condition again?
Okay. I believe your condition is related to infection, which is what we known as HIV.
Ah, HIV. What, doctor? You say I got HIV?
This is one of my uh, uh, one of our possible diagnoses, but I will need to run some tests or to in order to confirm it.
Why, doctor? Why you say you got HIV?
Probably is due to the infection that uh, you got it when you have an intimate relationship with your partner.
But that's like 1 year ago, doctor.
Yeah, but it is still possible. So that is why we need to run some tests on you, blood test.
Okay, doctor.
Okay, so is there anything else I can help you?
Yeah, yeah, doctor. Can you keep a secret between us? Like you say I got HIV. I'm very worried.
Sure, I can see you are very worried, but rest assured that all the information is kept confidential between us.
Okay, time's up. So, Dr. Chiu, can you go through anything positive on your history and examination, and then you list out your diagnosis?
Okay. From the history, the patient is 32 male with the presented with the progressive dysphagia associated with odynophagia, and also patient is having weight loss and also symptoms suggestive of tuberculosis, which is night sweat, and she also had a history of unsafe intimate relationship. Examination noted there is oral thrush with cervical limb adenopathy.
Mm-hmm.
So putting all together, my first provisional diagnosis is um, esophageal candidiasis, probably secondary to newly diagnosed retroviral disease.
Mm-hmm. Any differential?
Okay, my differential would be achalasia.
Okay, but why do you think this can be achalasia?
Because the only thing is because the patient is having the weight loss.
Uh-huh.
It can be due to esophageal malignancy as well.
Esophageal malignancy. Anything else in particularly for lymph nodes that you found?
Oh yeah, could be due to the tuberculosis infection in the esophagus.
TB of the esophagus, you mean?
Yeah.
Is that common?
Mm. Yeah, not common.
Mm. Okay, never mind. So, how will you investigate for this patient?
Okay, so to confirm my diagnosis, I would send the virus screening, HIV testing, Hep B, Hep C, and also I would do ESR, CRP, and I would
Sorry,
I
why you
would
want to do autoimmune screening again? Oh, ESR, CRP only,
yes,
just inflammation marker. Okay.
ESR, yeah, to exclude tuberculosis as well, CRP.
Mm-hmm.
And I would also send the sputum to check for PCP as well.
Okay. Only PCP?
PCP and also CMV and also candidiasis.
Candidiasis from sputum.
I mean to check for any fungal culture from the
Okay.
sputum. Yeah.
Okay. How we work out for TB then?
I will also arrange for the lymph node biopsy
Mm-hmm.
of the lymph node of the cervical lymph node, and I'll do a chest X-ray to look for any consolidation or PCP changes. And to exclude my differential, I will also arrange for the OGTS.
What are the things that you are expected to find if you subject the patient for OGDS?
OGTS, I would find there will be the candidiasis in the lining of the esophagus,
Mm-hmm. And
and
anything else you want to exclude from the scope?
I will also want to exclude the achalasia and to look for any intraluminal growth,
Intraluminal, so specific.
and also is there any mm,
Okay,
any
never mind.
yeah.
How will you manage the patient?
I would first education and counseling of the provide education and counseling to the patient, and the for the non-pharmacological management, I would prescribe the patient soft diet as the patient having difficult swallowing, and I would manage it with a multidisciplinary team involving the ID physician and
Time's up.
gastroenterologist. Yeah,
Yeah, but you can continue.
gastroenterologist, nutritionist, and also the pharmacist. For the candidiasis, I would prescribe the syrup nystatin,
Mm-hmm.
and I would
Wait. This is esophageal candidiasis. You want to give nystatin?
or it will be IV fluconazole.
IV. Cannot oral, is it?
Yeah, or yeah, it can be oral as yeah, oral fluconazole.
Okay. Anything
Yeah.
else?
In if it is a case of the HIV, I would counsel the patient and also arrange for the screening of the partner and to start on the antiretroviral therapy.
So when do you want to start the antiretroviral therapy? You want to start immediately, or you want to wait, or
I would I would um I would wait. Mm,
wait for?
Actually, there's no contraindication. I think we can start it once it's detected.
Okay, I think I will stop here. So what is your comment on this scenario and also your performance?
I think I couldn't find out other differential for the for this
Mm-hmm.
case.
Mm-hmm.
And yeah, I think I should be faster.
Yeah, so be faster is one thing. Yeah, and also I think your history is a bit too long and you are jumpy, yeah. So you are not systematic enough. But I can see a lot of improvement compared to the last time you attempted. I still remember you are very stuck, but now I think I can see you are quite smooth. Just that you are still, I think, can be better, can be improved. And then your history taking is actually, I know you got the flow there, but you don't really follow the flow. So let's say you ask about dysphagia, you have to ask everything about dysphagia first before you go to like systemic review or associated symptom. Because you ask quite fast and then you straight away jump to systemic review, and then after that you go back again here and there, and then go to past medical, and then after ask back the social history, and then you go back again. So you can see that it's actually quite disorganized in this way. Yeah, so my question to you is a patient smoker?
Yeah, I missed out that.
Yeah, so patient told you that he got a partner 1 year ago. Is it male or is it female?
Mm, yeah, missed out.
And what kind of sexual relationship they are having?
Mm, you mean orientation?
No, it's not orientation. I mean, as in sexual activity.
Okay. Yeah, I should dig more on that.
Mm.
Mm,
So, yeah, and your investigation, I didn't recall you mentioned anything about uh, CD4, HIV viral, and then just about viral screening, Hep B, Hep C only. Is that
mm,
all?
yeah. Mm.
Yeah. And the last part about the management, can you start HIV medication before you exclude TB? Because TB is one of the differential, right?
Yeah.
Mm. So sometimes you may not want to commit your answer yes, no. So you must give a clause like. So yeah, in this case, there is a need to exclude TB before we decide on the treatment. Because when you start anti-TB, I mean, if you start the RVD medication on the patient with active TB, what will happen?
The immune reconstitution iris, is it?
Yeah, patient can get paradoxical worsening of the symptom because of the iris. So you don't want that. Okay. So I still got a few more comments, especially the YY session about when patient asks you about the concern. So do you do you think you can do better by explaining that the patient have HIV straight? You say it's a infection in the throat, right?
Mm.
Do you think you can make it like a better way to
Yeah.
explain about
Actually,
candidiasis?
yeah. I wanted to say infection, but
What kind of infection?
mm, fungal infection.
So fungal infection, yes, some people may understand what is fungal, but some people may consider that some form of like a jargon.
Okay.
So and you don't want to mention that in particularly straight away jump to the HIV diagnosis, right? This is actually also a test for you on how you break the bad news and leads to the possibility of HIV diagnosis. You cannot straight away mention that I think you have HIV because you didn't mention anything about that until you ask, is the disease curable? Then you say no. Then if it's infection, why is it not curable? So it's a bit contradict, right? So
Mhm.
a better way to mention about this is actually you should tell the patient that I think, sir, I think you have a yeast infection in your food pipe. Okay, and usually this kind of infection means that your immune system is very low. For certain reason, we are not sure at the moment. But one of our priority is actually to exclude the possibility of HIV disease. Yeah, then you pause, then you wait for the surrogate response. So you don't have to, so you have a HIV. So this is a bit too, I would say, too straightforward because even in ConSkill also, HIV, although it's not a disabling disease, but because of the stigma, generally we still need to break the bad news. And this is definitely not the way you want to break the bad news, especially. Even in a consult scenario, you will realize that some of the question they actually tested us on this kind of com skill component as well. Huh? So
Mhm.
it's because you have like 2 minutes with the patient, and sometimes patient or surrogate only have 4 or 5 questions and you can answer quite fast. So sometimes you may also want to assess your communication. So you shouldn't you shouldn't just break the bad news without a pause and without doing it properly. So the
Mhm.
idea of kind of like giving this scenario is actually to test you how you want to tell the patient on the diagnosis. Okay, you don't want to tell you straightforward that this is HIV. And actually you almost miss out the partner issue. You didn't mention. I mean, you only asked about do you have any sexual relationship. The question is also a bit, I would say, a bit too straightforward as well. Straight away sexual contact. Actually, in overseas, that's not wrong. In Asian, probably you want to mention something a bit conservative first. You want to say that, sir, are you involved in any long-term relationship? Because your first question is actually, are you married? If I'm not wrong, after you ask me whether I want to ask some sensitive question. So because not all patient or surrogate is actually married in a scenario, and some may get offended if you say so. So why not you ask a very neutral question? Are you currently involved in any long-term relationship? Then the patient, if he's married, then say, oh, I'm married. If not married, they say no. But I used to have a partner. Okay. So a partner you may in this kind of scenario that you suspect RBD, you suspect TB, you suspect some infectious disease, the high risk behavior, you really need to ask everything in a bit detail. You want to ask about the partner. So may I know may I know your partner is a man or is a lady? And then you may want to ask a bit more. So when was the last time you have intimate relationship with each other? And then may I know how was the intimate relationship like? Is it protected or unprotected? And then is it um, involving genital tract as well as the bowel as well. So yeah, all these things is quite sensitive. But let's say it's this positive issue, right? You need to ask about that because you are dealing with a potential MSM, no? So you need to know because if you manage to ask the history of MSM, then the high risk behavior become very high risk. And sometimes, most often in real life as well, if you encounter any RVD patient or any patient that have high risk behavior, most of the time when they have the SI, they may also taken some drugs as well. So they may also taken some party drugs, taken some things to get them high as well. So this is something quite common, but I don't think it will be tested in the MRCP exam. But this is just a routine question. After you ask about sexual relationship, ask about party drugs, any illegal drugs, and then any injection of the medication, any sharing of needle, if let's say there is injection of medication, and then any tattooing or any ear piercing, and any recent travel. So all this must be like one package of it. Okay. So if you ask that, then you will get the history quite easily. Okay. So I would say if you, I I think you're a lot better. Your comm skill, I think you are quite fluent, but the problem is that I realize you tend to accidentally blurt out some of the jargon that you shouldn't do. Let's say you got abdominal pain or not. So you should avoid abdominal pain. And there's some other small things that you try to avoid. Try not to put any jargon. Your examination is okay, but I doubt you can complete the examination given that you actually examine the lung and also you examine the abdomen and you examine for the leg. So actually, like I always share, you need to give a good amount of time for examination, at least 3 minutes. So your history taking is actually until 10 minutes, and you only got like actually not 10 minutes, sorry, 10 minutes and 30 seconds. And when you examine the patient, you easily spend about almost 3 minutes already. And that is virtually like this kind of setting. If you want to examine the abdomen, you should do a palpation and then deep palpation and then some percussion. So that will spend easily 1 minute. And then if you examine the lymph node, also probably about 30 seconds. So want to check the throat, look at the shine the torchlight, and then check for goiter, right? So you actually don't ask for any goiter, you know. So in exam, you either ask patient to swallow, drink a cup of water, and you feel for any mass, anterior neck mass, and also you look at the mass whether there's any mass that move up with swallowing. So the I would say that the proper way to examine for thyroid is actually asking patient to swallow a cup of water. Okay, so if you want to do that, you must do it properly. Perhaps you are not wrong because goiter is one of the differential diagnoses. You do ask about whether preference only. Like I say, I try not to train everyone to become like very template. Do you have any weather preference? So it's like very robotic when you ask this way. So I would prefer you asking the surrogate, uh, do you afraid of hot or cold weather? You see, I mean, do it make it like a more common words because in real life you won't ask patient, do you have any weather preference? Just like that, right? It's a bit weird. So if possible, try to use a bit more normal kind of language. I think that will be better. Clinical judgment, I think is fine. But in terms of your investigation, you do miss out a bit of thing and you require some form of prompting. And then concern, I think is okay. But if some examiner thinks that you didn't really break the bad news like properly, then they may also minus your marks. Physical sign, yes, I would say the sign that I calibrated is only cervical lymph nodes, oral thrush, and no organomegaly. Okay, so differential diagnosis, I think is okay. You mentioned about fungal infection. You mentioned about esophageal candidiasis, which is also fungal infection. Some other esophagitis, probably you can mention about like CMV, which you only mention when you present during the investigation. So the next thing is the TB lah. So you have to exclude TB and also RBD. And then welfare, I think is fine. Okay. So most likely the diagnosis and the history you got is actually quite okay. I decided not to calibrate the hepatosplenomegaly again because I think a bit rush. And then yes, like I mentioned, but bear in mind that TB, not TB, sorry, a patient with RVD, there is always a possibility of lymphoma. This is something that you must put in the back of your mind. So the moment when you see lymph nodes, RVD, other than TB, other than fungal infection, viral infection, or even bacterial infection, you need to suspect possibility of lymphoma. Okay, and if you want to do it like even more impressive down the line, because patient travel to America before, you want to mention about Chagas disease, is fine. But 5 years, usually these Chagas disease, they are very, they don't have much symptom. They only manifest a few years later. So that's also another possibility. So another thing about achalasia is actually, what is the points against achalasia in this patient? Phil, can you hear me?
Yeah, okay.
Yeah. So what is the point against achalasia?
Achalasia won't have odynophagia.
Yeah, you are right in this sense. But again, achalasia, the symptom cannot be so short. No? So achalasia is something happen in the young age and actually progress. Okay, you got the ECAT scoring system, things like that. So they have a lot of this vomiting episode, regurgitation, and they also have a lot of this gastric kind of symptom, and they usually have prolonged duration. So achalasia is possible but less likely. And then the workout, yes, you also include viral screening, culture, X-ray, TB screening, lymph node biopsy. So this kind of patient, you also need a CT, most likely, because you want to look for any mediastinal limb adenopathy. And then, yes, I think you basically mentioned most of the thing, but I think your management can be better. So you need to think a bit faster, and then so that you can present smoothly. Okay. Anyone
Okay.
have any question? How about you? You have any question or not?
Yeah, I think I don't have any.
You don't have. Okay, right. I understand. So I would
Yeah.
say that you actually improve compared to previous session. I think we all agree, those that join in the past session, you are getting almost there, but you need to still practice. So I just want to talk a bit on the approach to dysphagia lah. So the first question you want to ask yourself when you encounter a scenario of difficulty swallowing is to actually differentiate whether you are dealing with oropharyngeal or esophageal dysphagia. So those that have my notes, you can turn to page 135. So you can see that actually the approach is quite simple. So you want to know the onset and then whether it's this sudden or gradual, like what Chiu asked. And then you also want to ask about the progression and then whether is it persistent or intermittent. Okay. Another thing is that you also ask about the timing because like patient like for example myasthenia gravis, they think the symptom get worse towards the late evening, and then at the same time the food, whether it's a solid, whether it's a liquid, and then the location itself can also give you a clue. So you want to differentiate. So you have to ask all question that will help you to exclude oropharyngeal dysphagia. That will include: is it difficult to initiate the swallowing? Does it get worse with liquid, but you still can eat a bit of soft diet or a bit of hard food? And then, do you have any food that come up on the nose when you swallow, or liquid that come up from the nose? Any cough, any choking, or any breathlessness? You did ask that, but you didn't ask in I would say at one go because you asked slowly and then intermittently. So if no, then you know that it's not oropharyngeal already. So next thing is actually esophageal. So you have to confirm. You ask, yeah, they will mention that the food start in the chest, worse with solid, the liquid, and then reflux. You want to ask a bit of reflux symptom, because that will tell you a bit more of gastric involvement. The next subsequent important question is actually the weight. Weight will actually guide you which direction you are heading. So the patient have a very obvious weight loss. That's why you must immediately think of this few possibility. You want to ask about appetite loss. You want to ask about any uh, I would say like achalasia per se. You want to ask about any both liquid and the solid actually beginning already have difficulty, not progressive. And then you want to ask about any early satiety, any family history. You want to ask early family history of cancer is fine. And then you want to ask about infection, fever, any traveling history, and then night sweat, cough, uh, uh, hemoptysis, like what you asked. And then you may also want to ask at this point of time any failure symptom, heart failure symptom, because uh, a patient, especially younger patient, they may have some congenital mitral stenosis or even some form of rheumatic heart disease that actually develop left atrial enlargement, and that can actually cause esophageal dysphagia as well. And then another two, I would say, probably another one more common scenario that came out in the recent years is the Palmer-Vision syndrome. So you also need to assess for anemic symptom, and then you also ask for any throat, any lips soreness, okay, or any abnormal smell, abnormal taste in your mouth. And then if you cannot exclude any, then you also need to assess a bit of the mood symptom, because if patient is very depressed and everything negative, like you don't have any red flag other than the intentional weight loss, then you need to think about globus hystericus or even towards like anorexia, that kind of history. But generally, it seldom come out in exam. If if the history not suggesting a weight loss, but it's actually localized to esophageal level, then there's only a few differential that you need to screen. The most important thing is to screen for connective tissue disorder, which is typically scleroderma and Sjögren's syndrome. And then next is actually the spasm and also the stricture, 2S. Usually stricture, they have a lot of this long-standing gastric symptom, okay? And burning sensation, bloating, pain over the epigastric region. And then spasm is usually sometimes they're doing cold water or even some form of chest discomfort is expected. And then for esophagitis is also quite important. Radiation is not something I will ask routinely, but I will just say that do you ever encountered any form of radiation in the past? Okay, and then drugs, yes, drugs is also important. Let's say it's elderly, got history of fracture. You either ask patient whether they got taken any bisphosphonate that can actually cause esophagitis. And then eosinophilic esophagitis usually very rare will come out. Usually there's some form of like asthma kind of history, atopy. Huh? So I also give a clue in my notes that how do you differentiate this history for esophageal dysphagia if you don't want to go by the weight loss alone. So let's say you have a reflux symptom, then most likely the symptom is more like gastric. So it's like gastric stricture, or even after you extruded, everything looks like a globus hystericus. Let's say there is odynophagia, like in this patient. Odynophagia and dysphagia at the esophageal level will suggest of is some form of esophagitis. It can be things like Barrett esophagitis, it can be radiation esophagitis, it can be drug-induced esophagitis or infective esophagitis. Like in this case, it can be due to fungal, viral, or even parasitic infection. No? So let's say dysphagia that is also chest pain, then you need to think hard about esophageal spasm and achalasia. Achalasia is also good to put in the back of your mind. There is a possibility of pseudo achalasia when there is some lymph node compression, extraluminal compression that actually manifests as achalasia-like syndrome. And then most importantly, strogen and scleroderma is important. And then in a patient with chest pain and then got alcohol history or any recurrent vomiting episode, you also want to consider the possibility of esophageal tear. Esophageal tear used to come out quite frequently, I would say, and it was also part of the RCP sample scenario in the old format. So something like a history of Mallory Weiss or even Bohavi syndrome, let's say there is evidence of bloating, uh, tummy pain, they may suggest some form of perforation instead of just tear. So that's also possible. So weight loss, very significant weight loss. Most important thing to rule out achalasia and pseudoachalasia, and also consider the diagnosis of esophageal cancer. Let's say it's a esophageal dysphagia with anemia alone, and then with or without weight loss, then you need to think about Palmer-Wilson syndrome. So this is usually how I approach the dysphagia when I prepare the scenario in the past. So hope all these tips can help. So if no question, then we will go to the next person. Who is the next person? Is it like Michelle or the other one?
Junmin, it's me. I'm Yo.
Oh, yo, okay. All right,
Yeah,
okay. So you're ready?
yeah.
Okay, so I give you 4 minutes here. You can
Mm.
start now. Okay, time's out. Dr. Yo, this is the patient, Miss Jane. You can start.
Okay. Okay, good evening, Ms. Jane. Dr. Yoga, I'm the medical officer in this medical clinic. May I confirm that am I speaking to Mrs. Jane, 25 years old?
Yeah, I'm Miss Jane, yes.
It's nice to meet you today, Ms. Jane. We are here to discuss regarding your health condition. Is it okay for you?
Yeah, sure.
Okay, Ms. Jane, can you roughly tell me why do you come to our clinic today?
Yeah, doctor, I have been having a lot of cough in the recent 2 weeks. I'm very worried, doctor. I feel very unwell.
Okay. For this course, is this for this reason 2 week, or previously you have multiple times of cough that is admitted to the hospital previously?
No. This is my first time having cough.
Okay. Does for these 2 weeks does it progressively getting worsen?
Yeah, I would say the symptom persistent and I'm actually getting weaker.
Okay. Do you have any flame associated with your cough?
Phlegm. Yeah, I do have phlegm. It's like yellowish kind of phlegm.
Okay. By any chance, do you have any blood inside your phlegm?
No,
Okay. Do you have any difficulty in breathing?
no,
No, any difficulty. Do you have any leg swelling over your both side of your leg?
no,
By any chance, do you have any difficulty breathing when you lie down in the position of the lying down?
no,
Okay. Do you suddenly wake up in the middle of the night because of difficulty in breathing?
no.
Okay. For this cough, you mentioned that it's just these 2 weeks. Previously, do you have any prolonged travel?
No,
Any any trauma to your chest region?
no. You mean injury? No,
Injury to your chest region?
no,
Okay. Do you have any chest pain?
no,
Don't have any chest pain as well. Okay. Previously, do you have any symptoms that you have difficulty in breathing that require some inhaler gas at the past of the time?
no,
Okay. May I know, do you have any joint pain?
no,
No joint pain. Do you have any muscle pain?
no,
Previously, when you're exposed to the cold environment, do you find that your fingers change in the color?
no,
Okay. Do you have any, when you're exposed to the sunlight, do you have any rashes over your face?
no,
Okay. Okay. Do you have any lumps and bumps over your neck regions or over your legs or over your hands region?
no.
Okay. Do you have any okay, may I know roughly what do you work as?
I'm actually not working because I have thalassemia for very long already, doctor.
Okay. Can you tell me more about your thalassemia? You have been diagnosed since when?
Yeah, this is since childhood. I remember I was very young. Can't remember, it was like 4 or 5 years old. So my whole family members have thalassemia. So I was required about 3 monthly transfusion initially, but now it's like 2 to 3 weekly. So it was quite bad. I require a frequent visit to the hospital, doctor. And I was told that my iron level has been increasing. So actually 3 weeks ago, I was just discharged from the hospital because of the surgery to remove my spleen.
Oh, okay. Okay, to remove your spleen. Okay, may I know what medication are you on because of your just now you mentioned that your iron level is high. Is there any medication that you are on now?
Yeah, it's the oral chelator.
Oral chelator. Okay. Okay. Is there any after your spleen removal from the hospital, is there any medications that you are discharged of?
Yeah. I was given some antibiotics.
Okay. How many types of antibiotic they do they give you?
Only one is called penicillin V.
Only penicillin V. By any chance do you take any antibiotic else?
Any other antibiotic you mean?
Yeah. Mm.
No.
Do you get prior to the arrangements of the spleen, removal of the spleen, is there any vaccinations that you have been undergone?
Yeah, the doctor given me a few vaccination, but I think that one is for the brain infection one, another one is for influenza, but I think I actually missed one also for the lung infection one. That one I didn't take.
Oh, the lung infection one you didn't take. May I know what's the reason that why you didn't take the medication? The vaccination.
Yeah, that day I actually forgot to pay for that, so it only influenza and the one of the brain infection one.
Okay, okay, understand. Okay, okay. Uh, do you have any excessive urinations or any excessive thirst?
No.
Okay, do you have any high body temperature?
Sorry, what?
High body temperature.
Fever. Yeah, I do have
Yeah.
fever associated with this cough.
The fever for how long already?
It's almost about 2 weeks as well.
2 weeks as well. Do you have any night sweats?
Not really. Just
Not
when
really.
I have shivering, I feel very cold.
Oh, okay. Okay. So you do have fever, you do have some night sweats and some cough as well. Okay. Do you have any change in your bowel habit or your urinary habit?
No,
Okay. Do you exposed to by any chance do you expose to any of your family members or your or family members or your friends that having similar symptom as yours?
no.
Okay. Okay. Do you have any loss of weight or loss of appetite recently?
My appetite wasn't great for the past 2 weeks. In fact, since discharged from hospital, because I don't feel like eating.
Okay. Okay. Do you have any additional breathing sounds such as high pitch additional breathing sound?
I'm not aware.
Okay. Okay. The questions that I'm going to ask you, it may or may not related to your symptoms. Do you have any dizziness?
Dizziness when I walk for a long distance, I do feel that, but at rest, I don't have any dizziness.
Okay. Do you feel that your dizziness is when you change in the position, like start from a lying to a standing
Yeah,
position?
yeah.
Okay. Do you have any headache?
No,
No, any headache. Do you have any blurring of vision?
no.
Do you have any rashes over your hands and also your legs?
You have asked me. I don't have any rash.
Okay. Do you have no difficulty? Okay. Uh, do you have any past medical history except from the thalassemia?
No.
Okay. Do you have any past surgical history except from the splenectomy that you have removal of the spleen that you have undergone?
No.
Okay. Do you have any drug allergies or any food allergies?
No.
Okay. Do you have any over-counter drugs medication that you bought recently?
No.
Any traditional medications that you are consuming?
No.
Okay. Are you a smoker?
No. I can't smoke.
Okay. Do you drink alcohol?
No.
Okay. Sorry, I need to ask you some sensitive questions. I ask this to all of my patients. I hope you don't mind, Mrs. Jane.
Mm-hmm.
Do you have any long-term partner?
No.
Okay. Okay. Do you involve in any illicit drugs as well?
No.
Okay. Okay. 25. Okay. Can I from the family, except from the thalassemia, is there anything that any significant family history that you would like to tell me?
Mm, my mom also have diabetes, but generally all my family members have thalassemia. There's no other medical problem.
All right. All right. Can I ask you some sensitive questions as well? How about do you have any bone pain or any previous fracture before of your bone?
No.
Don't have as well. Okay. How about do you have any hair loss?
No.
Okay. Can I examine the patient?
Yeah, sure. This is the patient.
Okay. 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 From the This is the patient. Okay, can I check the pump? Is that is there any paler over the pump?
As you can see, she looks pale.
Pale. Okay. How about the CRT? Is it less than 2 seconds?
So the CRT is actually about 2 seconds.
Okay. How about the pulse? Is it how's the pulse volume?
Pulse volume is just moderate,
Moderate pulse volume. Is it regular?
is regular.
Okay. Okay. Then how about the conjunctiva is pale?
Yes,
Is it jaundice?
you can see there's some tinge of jaundice.
Tinge of jaundice. I can see that there's a prominent maxillary and also mandibular region. Then is there any oral thrush?
No oral thrush.
Is there any palpable lymph node?
Which part of lymph node you want to palpate?
The over the neck region,
There's no cervical lymph nodes.
cervical lymph nodes. Okay. Can I take a lying and also standing BP?
Examiner say patient cannot perform, so you can skip.
Okay. The temperature, is it same as the STEM, 38.2 degrees Celsius?
Yes, she's also having fever.
Okay. Okay. Can I auscultate the lung? Is there any crepitations that I could appreciate?
There's no crepitation, but you do feel that the breath sound over the right middle zone is reduced as compared to the left.
Right, middle zone. Okay. Okay. How about the trachea? Is it deviated?
Trachea is central.
Central. Can I check the throat? Is there any uh, uh, swelling of the tonsils or any injected throat?
The throat appears dry, but there is no swelling. The
Okay.
tonsil.
How about the tongue? Is it coated?
Yes.
Okay. Can I check auscultate the heart? Is it do rhythm, no murmur?
There's a loud P2, but there's no murmur.
There's a loud people. Okay. Can I okay. How about the can I examine is there any axillary lymph node and the inguinal lymph node as well?
Examiner say you can skip.
Okay. Any hepatosplenomegaly that I could appreciate?
You want to check the abdomen?
Yeah.
This is abdomen.
The abdomen, there's a scar over the left, then appears. Okay. Is there any hepatomegaly?
Yes, there's hepatomegaly about 5 finger breadth below the costal margin.
Okay. Okay. Yeah. Is the abdomen soft and non-tender?
Yes.
Okay. Is there any bilateral lower limb swelling?
No. 2
Okay.
minutes left.
Okay. Mrs. Jane, can I know what is your concern?
Doctor, what is wrong with me, doctor? Why am I so sick?
Yeah, I believe that Mrs. Jane, I can see that you are very worried regarding your health conditions, but I think that the now you are having a lung infection is probably because likely is because of your prior to your spleen removal, you missed out the vaccinations, and now the spleen is removed and causing your immune system to be weak, and you are having a lung infection now.
But doctor, I'm taking antibiotic. As per what doctors say, right?
Yeah. Oh, sorry. Mrs. Jin, are you compliant to your antibiotics?
Actually 1 week ago I already stopped because I feel unwell, and then I only take occasionally, once a day.
Okay. Okay. Miss Jane, this is probably this is the cause that causing you to have this lung infection as well, because you miss the antibiotic that we have prescribed to you. But please be rest assured that we will admit you to the hospital, and we will give the antibiotics to you, and also give some hydrations to you, as you looks a bit dehydrated as well. Mrs. Jane,
Doctor,
is that okay for you? Mm.
is it serious, doctor?
Mrs. Jane, if the infection is not treated, then it could be serious, but we will admit you in the hospital, and we will give you the best treatment. Please don't be
Doctor,
worried, Mrs. Jane.
I actually refused admission. I'm really traumatized with the last admission. So much of stress going on. I don't want to be admitted, doctor.
Do you mind to share with me, Mrs. Jin, why is there anything that happened during the last admission that traumatized you?
Time's up. It's okay. So, yeah, Dr. Yo, can you run through all the positive finding from the history and examination and tell me about your diagnosis?
Okay, I have taken the history taking from this patient and also examined her. From the positive finding that I could appreciate from here, it's this patient actually presented with 2 weeks of progressively worsening cough, and this is the first episode associated with yellowish sputum, and also some fever for the past 2 weeks with night sweats and loss of appetite with some postural dizziness. And previously, this patient is a thalassemic patient, prosplenectomy with miss of the previous lung vaccination and also miss antibiotic for 1 week as well. For my examination, the patients appear to be fever and also tachycardic and also dehydrated, and also there's a post-splenectomy scar over the tummy area, and there's also thalassaemic phases and LAP-P2. So combine all this together, my provisional diagnosis for this patient will be it's a overwhelming post-splenectomy infection. Slightly, it's the lung infections, secondary to miss medications and also miss the lung vaccination.
Okay. Is there any differential?
My differential diagnosis for this patient could be pneumonia. Another differential diagnosis could be tuberculosis. Tuberculosis for these patients, and yeah, I think that's all for my differential diagnosis.
Have you checked the patient's scar?
Yeah, I didn't check the patient's scar. I should check whether it's infected or not.
Let's say it's infected. What is your another differential?
It could be infected post-splenectomy scar.
Just the scar infected?
Yeah, that's what I could think of for now.
Okay. How will you investigate this patient?
For this for these patients, I would like to take a full blood count to see for any leukocytosis, and also check for the HB level, as the patient appears to be pale as well. Then also to look for any thrombocytosis. Then subsequently, I will take a renal profile and also a full liver function test as my baseline, and the patient got dehydrated to see got any acute kidney injury or not, and also inflammatory markers such as ESR and also CRP. Take a sputum culture and so sensitivity, stand for sputum acidified bacilli, and also MTB CNS. Then subsequently, I will take a blood CNS for this patient as well. If the scar appears to be infected, then would like to take a swab CNS for this patient as well. Then subsequently, would like to for the imaging part, would like to do a chest X-ray to look for any consolidations of this patient, and also echocardiogram, as the patient's got a LAP-P2 as well. Then imaging, chest X-ray, echo. Yeah,
Okay.
I think that's all for.
Okay. How will you manage this patient?
For the management of this patient is a multidisciplinary approach, mainly patient education and also counseling. And would like to give a broad spectrum antibiotic for this patient, and also refer this patient to a respiratory physician. Start broad spectrum and antibiotics to cover for infection, and also trace all the culture and sensitivity, and give the antibiotic accordingly. Then subsequently, would like to stabilize the patient with ABCD, airway, breathing, also circulation, because the patient appears to be dehydrated. Would like to give some IV drip to the patient as well. Then subsequently, for the oral chelator, for now because there's evidence of infection, so probably need to withhold the oral chelator for now.
Mm-hmm.
Then, then look at the HB
Hi,
level
Song.
whether the patient is indicated for transfusion or not.
Mm-hmm.
Yeah.
So if you got like 10 seconds, what else you want to offer?
And also optimize all the dietitian and also advise the patient for the vaccination after this current admission.
Mm-hmm. Other than vaccination?
Vaccination. Then also after discharge, advise compliance to the oral penicillin V that is prescribed.
Yeah, exactly. Why you leave it like so back behind? That's the most important thing, right? Patient did
Yeah,
miss some medication, huh? So you don't have to wait until the end only you mention, right? Because you wait until the end, the time's out already.
yeah,
So yeah, another thing is that your management, right? Your
mm,
management cannot be start antibiotic first only A B C D E lah, oh. This is
yeah,
it doesn't make sense, right?
yeah.
So you must mention that yes, management is a multidisciplinary team approach.
Mm,
The priority is admitting the patient and then perform a sepsis care bundle. This will include every breathing circulation. Let's say patient require oxygenation, require fluid resuscitation, require blood transfusion, take the
mm,
essential bloods, and then may also require inotropic support. And let's say patient is having a shock, and then you mention about yes, after culture to start the antibiotic immediately, broad spectrum. Okay.
mm,
And then you also want to mention about things like isolation until the infection is excluded. And then you also want to mention about vaccination and also the antibiotic prophylaxis later. So I think you need to prioritize because
okay.
yes, at the acute state, you will mention about prophylaxis and also vaccination, but you should split your management to be like, it's either you want non-pharmaco or pharmaco, but certain scenario is better to present as acute management and then long-term, short-term management as well as long-term management. So depends on how you want to sell it. Okay. Yeah, I think you are quite okay. Huh? I can see that you are quite prepared. Just that you're also very jumpy, oh. Do you realize that your history is like everywhere?
Yeah.
Yeah, you
Yeah.
you ask me social history like 2 minutes of the history taking, and then you ask a lot of repeated question. You ask me a few times on bowel motion, urination. You also ask me about joint pain and rash. I remember rash also like 3 times. So
Mm.
so you must have your own approach. What have you written outside when you prepare a scenario? Cough 2 weeks.
Actually, I prepare is acute, chronic, and also intermittent. Then I differentiate to lung and heart. But it come out with the picture of the thalassemia, then I suddenly become confused already.
Mm. So
Yeah.
another possible diagnosis in this patient is actually, can this be post-operative immobilization causing pulmonary embolism?
Mm, okay.
Yeah, but definitely not the, can put under differential, but definitely not the first one because of fever, right? No hemoptysis. Okay, so but again, when you expand your differential diagnosis, right, pneumonia can
Mm,
be bacterial, can be viral as well, right? So,
mm,
so you don't have to put that just overwhelming post-splenectomy sepsis because of pneumonia alone. Oh, so it can be a lot of other types of pneumonia. It can be atypical pneumonia, bacterial pneumonia, or viral pneumonia. All this can be happen because there's no spleen and patient is not compliant in the past. Okay,
okay.
so yeah, and the vaccination part, you also need to ask a bit more. So usually we offer 3 types of vaccine, right? Pneumococcal, influenza, as well as the meningococcal. But nowadays, also need to make sure that the COVID vaccination is up to date as well. And yeah, you need to ask a bit detail on that. Another thing is that you miss the antibiotic compliance totally until the end.
Yeah.
Yeah, you realize that? So when you
Yeah.
when you ask about drug history, make it a routine that do you do you ever forget to take the medication, and then any recent change in the medication, and also any addition of medication, and also over the counter as well as so-called party drugs, or even you want to take traditional medication. So all that is quite important. Okay, so you must ask full set lah. When you want to ask about drug history, you should ask full set. But again, this kind of patient thalassemia, I don't know why you keep on asking joint pain, rash, fever. I mean, a lot of connective tissue symptom. It seems like you are not very convinced that she is a thalassemia, oh?
Yeah.
So it's quite easily recognized that this is like thalassemia, right? So I think
Yeah.
your history must be very orientated to your complaint, because this is actually a wet cough, wet fever. I mean, productive cough. You are not.
Mm.
You are. I mean, you don't really think about interstitial lung disease that far, and then at the same time you need to focus on this acute to subacute kind of cough. Can be pneumonia, can be PE, can be other things like heart failure, can be also from gastro point of view, got any reflux. So you want to mention about all that. And then, yes, the connective tissue to me is not that important for this scenario. More importantly, I want to ask is actually her condition. And then you want to ask about recent hospitalization, because potentially you may be dealing with hospital-acquired pneumonia, 2 weeks duration, but this one is 3 weeks. So then you will get the history of this admission, splenectomy. I think you need to ask that question instead of wait for surrogate to offer you, because thalassemia, there's a lot of things to really ask about it. Okay, and then splenectomy part, yeah, nothing much. Basically, you got most of the things. I would say it's quite a straightforward kind of scenario. So I think com skill, no issue. Examination, I mean the com skill, the only issue is that I would feel you are a bit jumpy lah. But I think generally you are still fluent. Examination, no issue. In fact, you don't know what to examine already. And then I don't know why you want to look for hepatosplenomegaly when there's no more spleen. So you must also think what you want to examine. So you want to examine abdomen, then I will show you the photo. So you don't want to mention that I want to look for any hepatosplenomegaly, just like that. So you just go, in the real exam, you will just go and then ask for permission. Any pain? Can I see your tummy? And then straight away examine, right? So concern, I think okay, but the last concern you didn't manage to address because patient refused admission. She already told you the reason, because she have a lot of stress last admission, overwhelming. Yes, it's good for you to ask again, but you know that you if you don't have much time, then you should try your best to just counsel, because it's not a proper com skill kind of scenario. This is just to assess your communication. And then physical sign differential diagnosis and welfare is okay. I think you can get most of the marks. It's just that you need to be a bit more organized, I would say. So yeah, another thing is that when encounter the scenario outside, right? So look at this blood pressure and the heart rate now. So before you examine the patient, you should already tell the examiner that, sir, I noticed that patient is hypotensive and tachycardic, also having active fever. And this fever is very interesting. You didn't ask me anything about fever until like maybe 7 minutes of the history taking, when you already know that the patient is fever before you enter the scenario. So this is very common. A lot of times when you miss the vital sign that is important, you may not think of want to ask the patient immediately. So automatically, this kind of vital sign, you know patient is having fever. So you should ask cough and fever early, not putting it at the back. And then you need to mention when examine the patient, I notice the patient is having tachycardia and also hypotension. Is it okay if I request for a new sets of blood pressure? And then this kind of patient, I won't, the BP is already low. There's no point to do a postural hypotension. Okay, postural hypotension is only when BP is normal and then having symptom, you want to confirm, then you can do. But it's already low, then we don't have to do the postural hypotension. It's unnecessary. And the SpO2 already 96, like borderline like that, right? So it's also important for you to make sure that you catch that part. Another thing is that I think under the investigation part, you mentioned most of the thing. Just the viral screening that perhaps that is also quite useful, because patients have regular transfusion. You don't know what's the patient viral status, so you also consider want to repeat again. And then yes, ABCD sepsis care bundle compliance. I think the most important thing in the exam is when you talk about your management, you should tell the examiner that you want to admit the patient, or you want to review the patient in clinic. I mean, can be treated as outpatient, okay, or you want to refer anyone straight. And the second thing is you should remove the trigger or the cause of the of the presentation. So let's say patient taken some traditional medication, develops some complication, or increase the dose of certain medication and develop complication. You want to mention that you want to stop the medication. Okay, examiner likes to hear that to actually target for that. Same goes to this scenario is due to non-compliance to the antibiotic prophylaxis. Then later on, when the patient is stable, you need to be counseled regarding the compliance and also review the vaccination, whether need to give it later on. So you must mention all this to address the contributing factor of the diagnosis. Okay, so that's extra comment for me. Any question?
No, thank you, thank you.
Yeah, anyone have any question? Most welcome. Yeah, if not, then we proceed to the last scenario, and then if you all have any question, can just comment in the chat box. So last is Michelle, right? Michelle, are you there? Hello? Hello, Michelle?
Hello. Sorry.
Hi, yeah, can you hear me?
Yeah.
Yeah, okay, so we can hear you as well. Are you ready for the last scenario?
Yeah.
Okay, so I will give you 4 minutes. Let me just prepare my timer. Okay, so 4 minutes start now. Okay, time's up. So this is the patient, Mr. Johnny. You can start.
Okay. Hi. Good evening, Mr. Johnny. My name is Sheen. May I confirm that you're 56 years old?
Yeah, I'm 66 years. I'm 56 years old.
Yeah. Okay. So I've been told that you have some blurry vision. Would you be able to tell me more about it?
Yeah, so doctor, I've been having blurring of vision, especially over my right eye. So this condition has been occurring for the past 6 months. Initially, I just feel a bit blurred when I look at right environment, but nowadays even when I at the dark environment also I will feel a bit blurred. I can't really see clearly, especially over the right side.
So you would say it's progressive.
Yes, yes.
Mm-mm. And are you wearing glasses by any chance?
No.
So do you feel is it worsen at night? Because
I
you
would
mentioned
say
it was dark. Yeah.
Yeah, I would say that in the morning, I can't feel it seems worse. At night, it seems better, but both is actually blurred.
So it's actually better at night.
Yeah, correct.
Okay. Um, do you have any pain with the blurriness?
No,
Do you have any do you notice that your eyes are ever red in color?
no.
Okay. Do you ever feel that it's a bit dry?
Mm, I don't really feel that.
Okay. So besides the blurriness, have you ever experienced any vision loss?
No.
Okay. Is this the first time that it happens to you?
Yeah, this is the first time.
So no previous episodes, yeah?
No.
Okay. Um, do you have any other symptoms that goes with the blurry vision?
Other symptoms, I'm not sure because I still can see. It's just that if I close my right eye, it seems clear my vision. So I guess it's only my right eye issue.
No issues with color, like seeing with color vision.
No,
Okay. Um, do you have any headache
no,
or dizziness that goes with it?
no.
Okay. So do you feel like sometimes you would bump into objects or have like falls because of this blurry vision?
No, no,
Okay. Um, just gonna ask you a few like general questions for your overall health. Do you experience any fever or chills?
no,
Okay. Do you have any like dry mouth that goes with it?
no,
Okay. Any like difficulty in breathing?
no,
Okay. Any chest pain?
no,
Do you feel like your heart is beating faster than usual?
no,
Okay. Do you experience any difficulty in swallowing?
no,
Okay. Any joint pains?
no,
Any rash or any like lumps or bumps at your skin?
no.
Okay. Do you feel like you're always more thirsty and then you tend to drink more water and pee more?
No. I think my urination has been the same.
Okay. So no issues with the bowel motion as well?
No,
Okay. Have you ever experienced like sudden like hot flushes or like sweating?
no,
Okay. Any swelling of the legs?
no.
Okay. Um, okay. All right. Do you have any medical conditions that I should know of?
Yeah, I used to have this reflux. Doctor told me I have stomach problem, and then I also have diabetes.
Okay. So how long have you been diagnosed with diabetes?
Yeah, so I have diabetes for almost 5 years now. I'm taking only one medication. It's called metformin, 2 tablet twice a day.
Okay. Do you know whether your control within the last 3 months, is it okay?
Yeah, I remember the doctor told me my 3 months kind of sugar control was about 6%.
Okay. So do you have any like experience any like tingling or numbness sensation at your fingertips or legs?
Yeah, fingertips. Speaking of fingertips, I think my right hand does feel a bit numb.
How long has this been?
I think it's about 6 months, but then in the recent 3 months, I feel it's getting more obvious.
Okay, so recent 3 months as well. Okay.
Mm.
Do you realize that when you pee, your urine is more like frothy, like bubbly?
No.
Okay. So besides the metformin, are you taking any other medications?
Yeah, I'm also on this pantoprazole because of my reflux.
Okay. For your metformin, do you usually take it or sometimes you would forget?
I'm actually very compliant. I never miss it.
Oh, that's good. Okay. Do you buy any medications from over the counter?
No,
Okay. Do you take any like herbal medications or supplements?
no.
Okay. Any drug allergies?
Not that I'm aware.
Okay. All right. Just a bit on your social sorry, do you have any surgical history?
No, no.
Okay. Just a bit on your more of your social life.
Mm.
Yeah. May I know what do you work as, Mr. Johnny?
Yeah, I used to work as a construction worker, but I already retired.
Okay. Has this blurry vision affect like your daily activity or the how
Yeah,
you
I mean,
Mm.
I can't read my newspaper every morning because of this blurriness. I need to close my right eye, and I can't. I'm very worried, doctor. I'm worried that this vision will get worse, and one day maybe I can't see.
Sure. I understand your concern. I mean, definitely it can be daunting. I'll have to ask a few more questions and then probably examine you before we get back to that. Is that okay?
Sure, sure. Thank you.
Yeah. All right. A few sensitive questions. I do ask this to all of the patients. Do you smoke?
Yeah, I'm a smoker.
How many cigarettes would you say would you
I would
be
I would
smoking per
s-
day?
I would say I usually takes about 2 pack every day,
2 packs. And how long have you been smoking?
almost 25 years.
Okay. So smoking is actually bad for your health. I would really advise you if you could cut it down. But we can probably refer you to like a smoking cessation clinic if you're keen.
Yeah, I'm actually keen, just that it's difficult for me to cut down.
Okay, we will discuss more about that later on as well. Um, and do you drink any alcohol?
No.
Okay. Sorry, are you married currently?
Yeah, I stay with my wife and two kids.
Okay. Do you have any unsafe or intimate relationships?
No, just with my wife only.
Okay. All right. Okay. Um, is it possible if I can just do a quick examination on you?
Yeah, sure.
Okay. So first of all, I want to look at the hands.
You look at the
To
hands. These are the
Yeah.
hands.
Okay. All right. Do you realize that your hands are bigger than usual?
No. I think it's the same size.
Okay, so you like your ring and everything is still fits, right?
Yeah,
Okay. All right. So looking for any like fingerprint marks.
no,
Um,
there's no
okay.
fingerprint marks.
All right. Looking for any tremors.
No tremors.
Okay. All right. Then is there any like weakness, any pain around your limbs or anything?
No pain. It's just some numbness, doctor.
Okay, just numbness, huh? Um, like to check for like proximal muscle weakness, if there is
Okay.
any.
So you want to check for shoulder abduction and adduction?
Yes.
Yeah, both are normal.
Okay. Even with yeah, okay, and then even when the patient is counting like up to 30, and then I mean doing the I'm trying to check whether there's any fluctuation after repetition
Okay, you want to check
changes.
for fluctuation. There's no fluctuation.
Okay.
Still strong.
Okay. All right. And then and now proceed to the eyes. So we would like to check for cranial nerve number 2, whether there's any dilatation or constriction with the light shine into it.
So you want to shine your pen torch. When you
Yes.
shine the pen torch over the right eye, it remains constricted. But when you shine the left eye is reactive, become constricted, and then the consensual right reflex is also very diminished. It still remain restricted over the right eye.
Okay. If I do the rapid torch shining, does the right eye dilate?
No.
Okay, so still remains constricted.
Yeah.
Okay. And then I would like to check for the eye movement. So, Mr. Johnny, without moving your head, would you be able to follow my fingers without moving your head? And then I'll do the H sign to check for any like ophthalmoplegia. Is there?
So when you do a H test, patient there's no ophthalmoplegia per se. Patient can look at all direction without seeing double.
Okay, and then trying to see whether there's any like proptosis or exophthalmos as well. From the picture, it doesn't look like it.
There's no.
Right. Okay, no lid lag.
No.
Okay, all right. Okay. So then we'd like to check for the sense. The sensation.
Okay. Which one you
Okay.
want to check?
For she mentioned there's fingertips, so pinprick and light touch.
So you want to check from the shoulder up to the.
From the peripheral up to see whether there's any like growth and stocking distribution.
Okay. How do you want to check?
From the fingertips and then slowly move up. Can you just tell me when can you feel the sensation? Yeah, would you be I will first try using either the forehead or the chest to see that's the sensation and then confirm it with the hips. Yeah.
So when you want to check the chest is sharp, the thumb is also sharp, middle finger is also sharp, but you check here is actually reduced. Here is
Sorry?
also
Where?
the little finger as well as the dorsal aspect is also reduced. The medial aspect.
Okay. And then the soft touch, is it for both hands or is it just the right?
Only the right hand.
Okay. And then any with soft touch?
So soft touch is the same. So he seems to feel here, but as you go this little finger and also the medial aspect of the forearm as well as the wrist, he can't really feel.
Okay. All right. So I would like
2
to
minutes left.
Okay. Check for vibration as well.
Okay. So when check for vibration, the thumb can feel. Which one you want to go? The thumb is already can feel.
Okay. So if the thumb can feel, then I'll stop from there. So Mr. Johnny, I understand that this blurry vision has affected you and you're quite concerned about it. May I know, is there any like specific questions you would like me to address?
Yeah, doctor. What do I have? I'm a bit worried.
So from your symptoms, I'm actually thinking whether this is related to your diabetes, because sometimes diabetes can affect some nerves of your eyes as well as the back. So it could potentially affect the vision of your eyes. So we would like to refer you to an ophthalmologist as well, and then do some blood tests to confirm with our diagnosis.
I see. Doctor, will my vision gets better?
Usually, there are laser therapies. Depending on the findings, they potentially have laser therapies, but all these treatments are to prevent progression of the blurriness. If the blurriness potentially will not get worsened once you receive the treatment, but it probably would not go back to what it was before.
Yeah. Do I need any surgery?
Surgery as in Usually, if it's laser therapy, it's just a procedure which can be done as a day case.
Okay, all right.
Mm.
All right, time's up. So, Dr. Michelle, would you mind to go through the positive findings from the history and examination and tell me about your diagnosis?
Okay, so I've examined Mr. Johnny, who's a 56 years old diabetic patient for the past 5 years, with a fairly good control with a HbA1c of 6%, but presented with blurry vision for the past 6 months, unilateral at the right eye. He felt that it's worsening and it gets better at night. Aside from that, he also complains of some reflux as well as numbness at the fingertips. Review of systems otherwise are negative, and he's also an active smoker. So my in terms of
What's
examination.
your examination finding?
Yeah, examination findings wise, there is cranial nerve number 2, it's affected. So it doesn't it remains constricted despite the light not shown to it. And then there is also peripheral neuropathy associated with it. So my provisional diagnosis is that this patient might have diabetes retinopathy. Possible other differential diagnosis may include cataract.
So what was the sign that you detected over the eye?
It's a aniscoria with
Mhm.
negative with positive RAPD, rapid afferent papillary defect.
But you didn't check positive
Yes.
RAPD? You didn't check for
Yes.
swinging light patch, right?
Sorry.
You didn't check for any swinging tests over the both eye.
I mentioned to swing, but then you said there is no.
Oh yeah, then there's
things.
no RAPD.
Yeah, there is no RPD.
Mm.
That's why my differential is just DM retinopathy or potentially
Okay.
cataract. Yeah.
And how do you explain about one-sided peripheral limb numbness over the hand?
It can also be like mononeuritis.
In particularly, you mean
Uh,
mononeuritis multiplex?
flex, yeah.
Okay, all right. So, okay, how will you investigate this patient?
So for this patient, I would like to send for the metabolic bloods, so which includes the HbA1c, the fasting lipids, fasting blood sugar, FBC, and then just to check for renal function and liver function in terms of the diabetes control. Then I would like to send for thyroid function as well. I would refer the patient for
Investigation.
investigate. Yeah, and then potentially can do an MRI or BIT or CT or MRI brain.
Okay, all right. So, just going back to the differential diagnosis, other than diabetes, is there any other possible differential for this patient?
So to pancreas
I think,
tumor with possible owner syndrome.
Sorry,
Sorry?
that's not me.
Yeah,
Um,
yeah. So someone that mentioned that just now, can you mute yourself? Because this is her session.
Yeah. Okay. So I'm also thinking about like optic neuritis, but usually it wouldn't be, the duration would have been that long, like 6 months.
Yeah. So just now when you ask the patient, there's also a strong history of smoking. So do you able to correlate that with your findings? So you say that it's reduced sensation over this is which region?
C8 to T, C7 to T1.
You are with
Mm.
another person, is it?
No, I mean, I'm not sure who's that.
Yeah, I'm so not sure. Yeah.
Rasliana, kindly mute, unmute.
Sorry.
Yeah, so yeah, Raziana, you're not supposed to tell anything, huh? Because you will compromise the candidate
I'm sorry,
uh,
doctor. I forgot. I forgot. I haven't mute my phone. Sorry.
So okay, so she told you that this is potential. I mean time's up, but never mind. We can still discuss.
Okay.
So do you think that this is if it's like a C8 distribution, right? And then up here is about T1. So with this kind of right meiosis, what is your possible differential?
Horner syndrome.
Yeah, you're thinking about Horner, right? So
Mhm.
just now when actually if you miss out all the history, but looking at this patient, if you examine the patient a bit more detail, you should able to detect this is Horner. So my question is that why you didn't check for Snellen chart
Oh yeah.
for visual acuity? So you want to check for second nerve. Second nerve is just not about torchlight checking for pupil reaction, right? So you also need to make sure that is it reduced vision based on, I mean, in terms of the acuity particularly. So you must complete the second term first before you want to go for 3, 4, and 6, right? So you should also complete the whole set. Yes, swinging light test is also one of them to check for RAPD. But in particularly, if you look at this patient, so the same as when you see this kind of patient in neuro showcase as well, the most striking thing is actually uh, one eye is actually constricted, another eye is dilated. But because this is actually an easy form of scenario, because you can ask history, in the short case you can't ask, so you need to decide which eye is abnormal. So therefore you check for the pupillary reflex. Just now after you check, what is your impression based on the finding?
Mm, I mean, it's still constricted, so that's
Yeah,
why
remain
there is
constricted, right?
yeah.
It
So
remain
there's
constricted.
so there's a
So
quick
so
illness
the
number
yes, so
two.
you
Yeah.
know that this is actually a third nerve, right? In a way, but it's actually not a full third nerve because
Mm.
there is no other like medial rectus palsy, the 3, 4, and 6 seems intact. Okay, so you think that this is maybe third nerve, and it looks like isolated third nerve with a constricted pupil. So when you approach the third nerve, right? And third nerve is after excluded that the left eye is normal lah. Left eye is active. When you shine the torchlight over the right eye remain constricted, but there is a consensual response over the left eye. So you know that the left eye is normal because direct and consensual is present, but the problem is the right eye that is remain constricted. So in this kind of scenario, you need to know that and look at the eye. Do you think that she have mild ptosis?
Potentially. But both of them actually look the same.
Yeah, so again, this photo is a bit rotated in a way that try to compensate a bit. But you look at the limbus here. So you look at here, it's not that obvious. But that's why if you want to ask the patient, you should ask the patient to look up as well. And then I will tell you that actually there is a ptosis. But because if you didn't mention specifically that you want to look for ptosis, then you may miss it. So sometimes the ptosis can be quite subtle. So the idea is that you need to make sure that the eyelid is actually same, but when in a so-called unequal or anisocoria, you may not able to appreciate it very well. So this is another pitfalls. Okay, so you check for the other 4 and 6 is normal. So you're thinking that this is maybe isolated third nerve, because when you check the second nerve, right? If you check the second nerve, as in you check the visual acuity, I will tell you that the visual acuity is actually 6 out of 12. It's just almost the same as the left eye. Then you know that then second nerve seems intact or seems very unaffected. So then you need to think that can this be medical third nerve palsy, like isolated third nerve palsy? Okay, so and the hand, the way you check sensation, you cannot straight away check check the distal sensation and look for peripheral neuropathy. So you should start from the front. I mean, you want to check the upper limb, you have to perform a proper upper limb examination, check the power. Yes, check the proximal and the distal. Okay. So in this patient, if you check the power, both proximal and distal will be full. But when you check the sensation, you should also check from the C5, C7, C6, C7, C8, and T1 accordingly first before you decided you want to check for glove kind of distribution, because you don't want to miss high lesion. Because if you only do from the bottom, if you don't start from the shoulder and the forearm, you can potentially miss a high lesion. So, and look at this hand. Do you think there is some discrepancy other than thinking that this hand is a bit big because of the vision issue, the zooming kind of effect? But look at this hand. Do you think there is some difference?
There's some small muscle wasting at the right hand.
Which aspect?
The tenor eminence area.
Tena eminence, or it's a hypotena?
Um,
Yeah,
hypotena.
it's actually more like hypotena, right?
Yeah.
Here it's quite full. You can see it's rounded, but here it's actually quite flat, no? So there is actually a hypotena eminence. So looking at that, so neuro actually you need to really inspect properly because the sign is there. You just need to catch the sign. If you don't catch the sign, you will miss the diagnosis. So you look at this, you see that there is a small muscle wasting over the T8, C8, and then possible T8. So that's why you need to ask. In the real exam, you need to ask the patient to show up to the forearm and also the arm so that you don't miss any muscle wasting, especially the forearm, medial aspect. So if you do that, I will tell you that actually there's a medial forearm wasting. So you know that, so there is some wasting. This gives you a clue that you are potentially dealing with Horner syndrome. Okay, so and the point against diabetic in this patient is the HbA1c is 6%. And there's not much of the end organ damage for the history, right? You asked me about frothy urine, you asked me about numbness. I only tell you one-sided numbness, and then you also asked me about any chest pain before. Do you ask me about stroke? I can't remember about any weakness over the limbs. I think in a way you did indirectly ask me. So there's not much of end organ damage in a very good control diabetes for just 5 years on single agent. That makes the diabetic presentation a bit unlikely, right? So that's why you need to think a bit extra whether you're dealing with something else. But what is most striking from the history is the smoking. All right, it's a very heavy smoker. So you think about things like if you're thinking that this is actually a so-called now that you know that this is potentially Horner and with a strong smoking history, what is your differential?
So like a pancreas tumor.
So thinking about lung cancer.
Mm,
Yeah, so that's why you need to examine the lung.
okay.
Yeah, if you don't examine the lung, you will miss out any scars or any consolidation or any collapse. So it's important, no? So this case definitely, because you didn't get a diagnosis, I will just skip the score sheet. But you know, in exam, this is something that can very common. I'm a bit surprised that you did not. You actually you do the systemic review quite well, I would say, and you are very fluent. Initially, I was like, I'm having a very good expectation on you because you seem very smooth. But I don't know why you didn't ask about constitutional symptom in the middle age to elderly, as well as you didn't ask anything about cough. I'm actually waiting to give you the clue of cough, but you didn't manage to ask about cough. You asked about SOB, chest pain, orthopnea, asked about leg swelling, and then you asked about GI symptom, GU symptom, but you didn't mention anything about the cough. Because if you ask me about cough, and then next thing, if you say it's a dry cough, then you're definitely going to ask me about constitutional symptom. And if you do that, you shouldn't miss a diagnosis, you see. So that's why it's important for you to really, sometimes the diagnosis is something we didn't think of, okay? When you prepare the scenario outside, you won't write the diagnosis, you won't think of that diagnosis for sure. But so your diagnosis should continuously evolve as you get further history. And therefore, it's important for you to do a good systemic review. You have done quite a good systemic review. You ask a lot of connective tissue symptom. You ask me pretty much most of the thing. Myalgia, arthralgia, what else? Skin rash times 2. I think got some other uh, ulcer or even some other question, soreness. But you didn't ask me about cough, and also constitution symptom, which is important. And judging that kind of history of smoker, heavy smoker in the middle-aged man, definitely you will need to U-turn back if it struck you that can be some form of lung malignancy. So that's why it's important. But I quite happy that you try to screen for some other potential causes like any lumps and bump, especially any neck swelling, any thyroid symptoms. and then any surgical history in the past. That is something I actually quite happy with, because you're trying to look out whether there's any compression. But I don't know whether you think of corner when you ask about all these questions. Do you think of that just now?
No, like my differential outside, I was thinking like whether it's like thyroid, and then the
I see.
migraine tolerance or myasthenia gravis or dystrophy myasthenia.
Mm,
Yeah, so that's why I didn't ask about the cough,
yeah.
because my review of symptoms is very skewed towards my differential diagnosis that I wrote outside.
Mm. So you see, probably later we can discuss how do you approach blurring of vision as a scenario. But just to continue the discussion for this, you know that this is a Horner already lah, huh? Because the partial ptosis in this photo, I agree, is not obvious lah. In the real life, you have to see the eyelid, and the pupil margin. Actually, there is this certain measurement, but basically the general idea is that if the eyelid in a resting position, it covers covers more than 1/3 of the distance between the pupil as well as the sclera, the upper sclera. So that kind of more than 1/3 thing is already considered as ptosis lah, to define as a ptosis. Okay, so sometimes the ptosis can be quite subtle. Okay, so there's no chemosis, and then if you think this is Horner, so you may want to do it differently, in the sense that you want to check the neck. You want to look for any scar, lymph nodes, thyroid, escorted for any bruits, any cervical ribs, sometimes can cause compression to the vessel. And then you want to check for Horner. In particular, you want to check the power and also the sensation. So most of the time, the power is normal, huh? Because Horner only affect the sympathetic nerve, and especially at the C8 and T1 level. So that's why the power is unaffected, but the sensation will be reduced over the C8 and T1. Okay, so in this kind of condition, you should check the lungs. If you check the lungs, I will tell you that there is actually a bronchial breathing. So another thing I didn't calibrate is actually you must also check for tracheal deviation. So any lung examination will not be complete unless you check for tracheal deviation. Okay, so if you check for tracheal deviation, this one you're actually deviated to the right side, and there's a increased vocal resonance with bronchial breathing. So you can also appreciate there's some muscle wasting, but there's no proximal weakness. Okay, so if you get this kind of approach, then your diagnosis will be right Horner, secondary to possible Pancoast syndrome, right apical lung consolidation. However, because of the history of constitutional symptom with dry cough, there's always a possibility that you are dealing with some form of secondary lung malignancy, or you can also dealing with some form of cavitating pneumonia or cavitating lung lesion like TB or fungal infection. Okay, you may also want to put down the list differential diagnosis of diabetic with complication and organ damage, but which is less likely because the control is good only on single agent. Okay, so I mean, investigation management, we just go through. You need the X-ray to look for consolidation, CT, PET later for staging, and then want to screen for, if you think this is lung cancer, you want to look for paraneoplastic complication, which may include hypercalcemia of pregnancy, also include SIDH, also include cortisol secretion, so ACTH and dexamethasone suppression test, liver function test, lung biopsy. Okay, and then management will be something like refer to chest. Definitive treatment will depends on the HPE finding involving the oncology and rehab. And also in this patient, even if you didn't manage to get the diagnosis, you can still mention things like smoking and stop smoking and vaccination. Like I said, if the diagnosis is directly contributed by the cause, then you should try to reverse it or you should stop it. And then if you think that this is a lung cancer, risk of infection is also very high. That's why you also have a role to consider vaccination later. Okay, so that will be this kind of approach. So I just want to go through this Horner kind of approach, because this can be relevant for short case as well as in long case, as in consultation. We need to know that in the Horner syndrome, basically how you detect it is actually unequal pupil, which is and the unequal, you actually don't know which side is unequal, because it can be one side, it can be directed surgical tunnel palsy, the other side can be Horner. Okay, so you need to know that which side is abnormal. So if it is a consultation, it's very simple. The patient can tell you. If this is not a consult scenario, this is a short case neuro station, then you need to shine the torchlight You need to check for the visual acuity. You need to check for the RPD to decide which one is abnormal. Okay, so Horner, you will get the partial ptosis at the same eye with the constricted pupil or miosis, and then generally the rest of the sign is just negative. You may ask for reduced sweating, but most of the time may not able to get depending on the order of the involvement. So it's also worthwhile to actually understand this whole concept of the neuroanatomy localization, because it's difficult to know what are you finding unless you know that what kind of trajectory and the tributaries that the nerve actually goes through. So we need to know that from the hypothalamus, the first order is actually started from the hypothalamus, went up to the pons, the medulla, and then it actually stopped at the level of the sympathetic trunk, which is at the T1 in the spinal cord. Okay, so beyond the spinal cord until the superior cervical ganglion, this is the second order. Okay, and the third order is actually anything distal to the superior cervical ganglion, go out the way to the common carotid, internal carotid, and then go up and then enter the cavernous sinus, orbital apex, and then finally go into the ciliary nerve and supply the constriction of the pupil. Okay, so any order is important because different order will tell you a different thing. So how do you examine the Horner is that at each different level of compression or involvement, you expect a different pathology. So let's say this is at the level of the medulla or the pons, it can be lateral medullary syndrome. That's why in lateral medullary syndrome, you get Horner because it actually compresses on the brainstem. And then if let's say it involves the spinal cord, things like transverse myelitis or demyelinating lesion, or even like some form of cervical myopathy, sometimes they may have syringomyelia. And central cord syndrome can also present as Horner because it traversing through the path. And then yeah, so it's mainly first order you're dealing with these 2 or 3 diagnoses. From T1 to T2 or to the superior cervical ganglion is mainly the lung apical cancer, the tumor, anything that actually at the upper part of the ribs, especially the lung cancer, cervical rib, any very obvious lymph nodes, or even some form of aortic dilatation or dissection, it can actually compress on this area, and that actually causes second order Horner. And then the rest is just more like a third nerve kind of approach, because actually from superior cervical ganglion up to the orbital apex, passing through the superior orbital fissure cavernous sinus, is basically you are looking for whether there's any combined fourth or sixth nerve palsy, as well as you want to auscultate for any, because it passed through the vessel, you want to auscultate for any carotid fluid to suggest any dissection or any thrombosis. Okay, so knowing this anatomy is important because you will know that what are the things that you want to look for. So you always check, because it's a unilateral ptosis, partial ptosis with meiosis. So you want to check from the cranial nerve first. So I will confirm the diagnosis that this is a meiosis. This is actually at the affected eye. And then I will look hard for second nerve. After that, go to 3, 4, and 6. And then at the same time, because I know that if this is a lateral medullary syndrome, it will also have nystagmus. So that's why it's important for us to look for ipsilateral nystagmus in this condition to suggest that this is actually lateral medullary syndrome. Okay, and then after that, you also need to check for V3 to V5, which is the fifth nerve. We'll check for the sensation of the fifth nerve to actually look for 2 things. If you're dealing with lateral medullary syndrome over the right side, then you expect to find a reduced sensation over the right face, particularly at the V1, can be V2 or V3 as well. But usually the V1 is the one that you lost at the beginning. So all you want to look for cape-like distribution to suggest syringomyelia, meaning to say when you check for the, you have to you not only have to just use the cotton wool to feel for V1, V2, V3, you also need to feel the nose, just touch on the tip of the nose and compare to the side. So cape-like distribution will suggest syringomyelia, in which the nose, the patient cannot feel, there's a reduced sensation in the nose, but as you go periphery, like near the maxillary area or near the hairline of the forehead, you'll see that the sensation is there. So this is like cape-like a cappella kind of distribution. Then this will suggest syringomyelia. Okay. Next, after you check that, you may want to go down to the upper limb. But before that, I will still go by head to toe. I will go to the neck. I will look hard for any scar, any lymph nodes, any neck swelling. I will ask patient to swallow a cup of water and see any neck swelling. I will also feel for any lymph nodes, and I will also at this point of time put my stethoscope at the upper part of the cervical rib, particularly at the clavicle, and to listen for any supraclavicular breaths, and then I will go to examine the lung. So I will examine the lung. Basically, I will look hard for any scar first, because some patients they have pancreas tumor, which is already resected. So what you see is just lateral thoracotomy scar alone. Okay, so they may have done some upper lobectomy. So for that reason, you want to look for any scar. If there's no scar, then you listen, you auscultate, and then you do your vocal resonance, at least auscultation and vocal resonance, and then at the same time, don't forget to feel for the trachea, because sometimes the trachea can be deviated. If there's a scar, lateral thoracotomy, definitely you need to feel for trachea, because you don't know whether this is a pneumonectomy or lobectomy, or even upper lobectomy or lower lobectomy. And then after that, only I will check the upper limb examination. So it depends whether you want to complete the neuro kind of examination first, or you want to go head to toe. To me, if you think want to confirm honor, that's not wrong if you go to check the upper limb, and then after that you go back to the neck, and then only then you go to the lower limb. Lower limb is not important to me if let's say you don't have time. The more important thing is the upper limb. You want to check for the tone power and the reflex. Particularly, you want to go very fast for the sensation. So sensation, you want to check for two things. First is the C8T1 loss of distribution that will suggest honor. And then second thing is you want to look for whether there's any hyperreflexia, any presence of Hoffman sign that will suggest myelopathy, which particularly points to syringomyelia. Okay, then basically that's all. That's all for honor approach for examination purpose. So if you do all this examination, you should able to tell which level of honor you are dealing with, and you should also offer some differential diagnosis to actually explain if this is a short case. Okay, so if this is a long case, I mean, if this is a consult scenario, you don't have any much clue, so just bring a vision. How do you approach? So back to Michelle. What are the things that you wrote when you prepare the scenario other than diabetic? Or maybe you didn't write diabetic also, right? Or you wrote.
I wrote diabetic retinopathy or hypertension,
Mm.
and then thyroid, particularly like Graves' eyes, and then like potentially migraine with aura. But then yeah, I mean, because I don't know, initially I was thinking bilateral blurred vision, and then myasthenia gravis as well as myotonica dystrophy.
Sorry, dystrophy myotonica,
Yeah.
dystrophy. I see. So actually, another better way to actually prepare the scenario is you need to divide into unilateral or bilateral first, because both kind of approach is quite diverse, the differential, because you don't know which one. When you are at the side of preparing the scenario, you don't have any information on that. So probably you want to split into unilateral or bilateral, and unilateral is most often can be a few things. Okay, so it can be ophthalmal cause. Okay, ophthalmal cause like what, like cataract, glaucoma, papilledema, or even some form of optic neuropathy. I will put that as optic neuropathy, because most of the time optic neuropathy can only affect one eye. The other eye is very normal. Optic neuropathy can be divided into optic neuritis, anterior ischemic optic neuropathy, or other things like vasculitis, some other thing. But the idea is you need to put optic neuropathy. And don't forget that this blurring of vision, so this blurring of vision can be a few unilateral blurring of vision can also be due to third nerve palsy. So must always put the third nerve palsy under the unilateral visual loss, or even reduced vision, because if you put that, you won't miss the diagnosis. Okay, and third nerve palsy also include isolated or combined, so that's also important. Another thing is that this can also be second nerve palsy. Second nerve is usually the like what I mentioned, the optic neuropathy. So you can divide it as some form of ophthalmal condition. Ophthalmal condition like what we explained, the papilledema, glaucoma, cataract, sometimes optic atrophy, diabetic retinopathy, hypertensive retinopathy. There's another one that I want you to put in your back of the mind, which is less likely, usually younger age, which is retinitis pigmentosa. So all these are actually ophthalmal condition. But generally, it usually involve both eye lah, but it can also involve one eye more than the other. Okay, generally you can put like that. And for unilateral visual loss or reduced vision, if it's a neural cause, then you go by cranial nerve. So it can be cranial nerve 2 or 3. If it's 2, then you are dealing with optic neuropathy. Okay, if it's 3, then you are dealing with isolated or combined. So if you make it such a way that your approach is go by this direction, then it's easy. And if it's a bilateral, it's also quite easy. Bilateral is including everything that we discussed for the ophthalmic condition. Can have bilateral optic bilateral optic atrophy, bilateral papilledema, bilateral diabetic or hypertensive retinopathy. Okay, so those are the common cause of bilateral. And you also need to consider the possibility of neural cause. So neural cause of bilateral is not much, which is quite rare. So usually it's involved lateral gaze palsy. Those kind of condition is usually either lateral or vertical gaze. If it's a vertical gaze, you're talking about PSP lah, or paranoid syndrome. But paranoid syndrome, just forget it. It will not come out in exam. It's just too complicated. So it can be, if it's vertical gaze palsy, it can be due to PSP, progressive supranuclear palsy. It's like horizontal gaze palsy. It can be something to do with combined nerve palsy, combined nerve, or it can be due to things like what we call as 1.5 syndrome, but it's actually very rare as well. 1.5 or even what we call as I can't remember the term suddenly. It's either MLF or PPRF lesion. Suddenly my brain is stuck, but it's actually internuclear ophthalmoplegia. Yeah, INO. It can be INO. So there's actually only for the neuro. And then you think other than neuro, so you think go by level by level. So if it's a neuromuscular junction issue, then you are dealing with myasthenia gravis. If it's due to muscular issue, it can be a lot. It can be oculopharyngeal muscular dystrophy. It can be Duchenne. Duchenne can be, but usually rare. It can be more likely dystrophic myotonica. It can also be facial scapulohumeral dystrophy as well. Okay, so those are the muscle disorder, neuromuscular junction disorder, and there's also neuro causes, neurocranial neuropathy causes, or there's also ophthalmo causes. So if you think this kind of approach is a bit difficult for you to approach, there's also another way that I actually prepared the approach in my notes as well, if I'm not wrong. So I think it's actually under, let me check, it's under 116. Yeah, so those that have a note can go to 116. So when I prepare for exam, right, for visual loss, I actually do it a different way. Instead of, yeah, I also divide by unilateral and bilateral. But I tell myself that if this is a bilateral visual loss, right, so I will put the commonest being diabetic hypertension retinopathy first, and then I will divide my approach into a 3 direction. Let's say this is a case of bilateral visual loss. So I will screen for diabetic and hypertension because these two is the commonest. Subsequently, I will definitely go for 3 approach. First approach is whether I'm dealing with visual field defect issue. So because bilateral visual loss can also be due to pituitary, can also be due to stroke or even cortical sign. So I want to know at one spectrum, does the patient has any form of visual field defect? This is number 1. Number 2 possibility is actually whether there is actually any central defect. Okay, central defect meaning to say just enlarged point spot or even cannot see the middle, and then you're thinking towards like optic neuritis, optic atrophy, the optic issues. Or the third one is actually peripheral vision. Peripheral issue is mainly those that have impaired vision in the peripheral, which is actually the retinitis pigmentosa, papilledema, and commonly diabetic post photocoagulation, and sometimes retinal detachment. This is another possibility. And then the last one, which is the fourth one, is actually the ophthalmoplegia. Can be neuromuscular, like what we discussed, or can be third nerve with combined fourth or even sixth nerve palsy. So usually if you go by this, you should able to screen most of the diagnosis. Depending on which direction you want to use, there's no right or wrong way. Because I remember when I during my last exam, it was a case of blurring of vision. When I go in to the scenario, it was a double vision. So it's a bilateral visual loss. So is it bilateral visual loss? Yeah, I think so. Yeah, correct. So when I ask the patient, yeah, the patient is quite slow lah. So basically, there is some surrogate that provide the history. So basically, I can't find anything obvious. So my approach that time was the same. I try to see whether there's any which part of the eye cannot see. Look at the left or look at the right side. Which direction the patient cannot see more. The patient say actually cannot see right side more. Then I know that, oh, can this be hemianopia? So but I still continue to ask the question, do you bump into object at the side as you walk or cannot see the side over the both area? Then the patient say one side can the patient actually didn't say, but the surrogate say that the other eye no problem, but the right side is actually reduced. The left eye, the vision is actually still okay. Okay, then it give me more clue that this is right homonymous hemianopia already. But I still continue to ask. I ask about comorbid. I ask about vascular risk factor, hypertension, diabetes, and then ask about the symptom. Symptom also can help if it's like sudden onset or it's like subacute onset or it's like chronic onset. So this is more like subacute to acute onset, about 3 or 4 days of visual loss. And then I check his body. Basically, he actually got hemiparesis, but the power is like 4 plus. The other side is about 5. Okay, so it's not very obvious unless you check in detail. But again, when I examine the patient, I'm actually in the old syllabus, by the way. It's just like 8 minutes and 2 minutes thing, which is total 10 minutes. So as you can see that a lot of storm going on when we examine the patient and ask the history. So when I examine the patient, I actually want to find the Snellen chart because blurring of vision, right? You must check the second nerve because they will calibrate the second nerve for sure. And the problem is that I can't find the Snellen chart. My vision become very tunnel also in the exam. I can't find the Snellen chart. And it's like I want to offer. I say I want to offer to do a Snellen chart, but I didn't because the time is very rushed. So I straight away do what Michelle do. I also shine the torchlight, check the pupil is reactive. There's no ptosis. The cranial nerve 3, 4, and 6 is actually intact. And then when I check for the vision, it's memang right hemianopia, homonymous hemianopia. And then I know that this is looks like a cortical sign already. So I check for prenatal drift, the right eye, I mean the right side of the hand cannot lift up properly, but the power is otherwise still not too bad. And then I just complete my examination by checking the Babinski effects. And when I present my finding, that time was a case of I label that as a case of I can't remember. Let me check. Yeah, this is it's a right homonymous hemianopia. So it's actually a case of left. I actually put there the diagnosis as left cortical sign, can be due to stroke, can be due to space occupying lesion, can be due to bleeding, or can be due to demyelination. However, in view of the age and vascular risk factor, I will give a working diagnosis of possibility of left anterior circulation infarct, something like that. I remember I presented something like that. And then I remember that scenario, I actually got almost full mark, but unfortunately, my mark was penalized because of the I didn't check for a Snellen chart. I didn't ask for Snellen chart. And then when the examiner asked me before I leave the room, the examiner asked me, why you didn't check for Snellen chart? Then I told the examiner I actually want to check, but I can't find the chart. Then to my surprise, the chart is just pasted on the wall behind me when I examine the patient. So the whole consultation, when I enter the room, right, I didn't look at my back. So there's a very big Snellen chart at my back, and they actually expect us to check the Snellen chart properly instead of using the modified Snellen chart. So you can see that sometimes when in exam, you need to look at your peripheral surrounding very, very well, because sometimes you may have some clues that's important. If you walk in and you look at this Snellen chart and the scenario is blurring of vision, definitely you know that this is a scenario or maybe some form of second nerve palsy or some form of multiple maybe it can be multiple sclerosis or optic neuropathy, things like that. You must check the second nerve. Okay, so that station actually got penalized for I think 2 marks because one examiner minus 1 mark for the examination because they calibrate the visual acuity as one of the what we call as hard sign. Okay, so you can see that it's important for us to know how to approach. Blurring of vision can be difficult because you need to know which direction you're aiming for. But if you have your own approach, you classify into unilateral or bilateral, and then if it's bilateral, like what I mentioned, you actually split it into whether you're dealing with pupillary defect, as in whether it's a homonymous hemianopia or bitemporal hemianopia, because these two directions is totally different thing. Bitemporal hemianopia, you're dealing with pituitary lesion or some form of hypothalamus lesion that spread downwards into pituitary. You're dealing with more like possible man 1 syndrome, possible pituitary adenoma. You want to ask for a lot of these obstructive symptoms. Okay, if it's a homonymous hemianopia like my case in the past, then you need to rule out cortical lesions at the contralateral side. And let's say this is not pupillary, I mean, this is not the defect over the half of the vision, then it can be central, it can be peripheral. If it's central, then most of the time the RPD will be positive, and then you're dealing with something like optic neuropathy. If it's a peripheral, then you don't miss a diagnosis of retinitis pigmentosa and papilledema. Okay, retinal detachment is very rare, usually will not come out. And then let's say the rest of it is like what I mentioned. Always have a suspicion of diabetic and hypertensive retinopathy. So in this kind of scenario, ideally, if the pupil is not constricted, right, you need to examine the fundoscopy. You should examine the fundoscopy in this kind of eyes kind of presentation. So you cannot skip. You must offer to do, and they just mainly assess your technique. They may certainly give you a photo, a printed A4 photo with a fundoscopic photo, or they really dilate the patient eye. Then you need to think of looking through and look at the vessel whether that is suggestive of hypertensive or retinopathic changes. Okay, so another possibility is what I mentioned, which is the cranial neuropathy, whether you are dealing with third nerve involvement or third nerve with the clubs, or fourth or sixth nerve involvement, lateral gaze palsy, vertical gaze palsy, and then last but not least is the neuromuscular issues. Okay, but if you have your own approach, you just write down in your field, in your own mind map, then it's actually easy for you to approach. It's not that difficult. It's just that you need to have an approach, or else it's impossible to think of every single diagnosis in just 15 minutes, especially the first 5 minutes of preparation. Okay, anyone have any question before we end? Michelle, you understand?
Yeah, thank you so much.
Yeah, thank you. So you'll be where is your center again? Malaysia, right?
Malaysia, yeah.
Yeah, Malaysia. Okay, all right. So all the best to those that joining tonight. I know all of you, a lot of people is actually going for dietary, and therefore you are with me. So I may not able to do the session regularly because I really quite busy recently. But I hope that you all continue to practice, and those that have my notes continue to actually read through the approach and formulate your own approach, because my approach may not be the good one, may not be the best, I would say. So always find an approach that can cover most of the diagnosis, and also is easy for you to recall. So don't give a course for everything like A, B, C, D, E. So it's difficult to recall like A is what, B is what, C is what. It's difficult. Okay, so go by things like be a bit more flexible, I would say. Don't go by medical or surgical, pharmaco, no pharmaco. At different circumstances, when you present things, you need to go a bit flexible. You need to decide how you want to present it. You want to present the important one first, followed by the least important one, or you want to go by acute, long term, or short term, or you want to go by things like non-pharmaco or pharmaco, for example, for management. And then same goes to your presentation on the consultation to summarize the history and the examination. Actually, Michelle is the only one that actually during the presentation mentioned the patient name. Yeah, I have to give you a credit to that, because I hope that everyone, when you go in to present the examiner after we finish the whole consultation scenario, you can at least address the patient by the patient name. Don't say this patient, that patient, this uncle or whatever. Try to address the patient name. Like say this Madam so for example, Madam Sonia is a middle-aged gentleman. If you cannot remember the age, it's fine. Just mention about the important salient features in the history and examination. But to me, in order to make yourself feel professional, as well as you really give credit to the patient, it's better for you to mention the patient or the surrogate name, address them, or you really cannot remember, then you don't mention. You just put that you the last result is you mention like what they do lah. This patient presented with what, okay? And if you cannot remember the patient name, don't just confabulate with some random name, because it is better that you mention this patient than you mention the wrong patient name. So, but I think this is something of courtesy manners that will actually help you to give some good impression to the examiner. And another thing that when you all present the scenario to the to the examiner, try your best not to look at the patient, because usually patient will be inside the room with the surrogate. If let's say the surrogate is giving the history, or the surrogate itself is the patient, usually they will be inside. They won't come out, because the room is they try to prevent people from moving in and out too frequently. And then nowadays the com skill scenario don't have any more discussion, so the surrogate will not need to go out and then go in again. So most of the time, all the surrogate and the patient will be inside the room, and we all have a tendency looking at the patient, hoping there's an answer when you present something, but try not to do that. Just look at the examiner, take turn look at examiner, because most of the time, one examiner will be the primary, and the second examiner will just listen. They will not ask question. Usually only one examiner will ask question, but you need to maintain a fair, good eye contact to both examiner. Try not to just look at one examiner alone, because I think it's always fair to look at both examiner for all this kind of soft skill technique. And then, yeah, I think that's all. If let's say everyone have no question, then we will end our session for tonight. Okay, so thank you for